I'm Susan Moore for Banner Health and Spirit of Women, and today we're meeting the new doctor here at the Cardiovascular Institute, heading up the structural heart program, Dr. Michael Kim. Thank you. I know you're on call, so we'll have to, if anybody calls you, I know that I'll have to finish this up by myself. But please tell us, what is structural heart program?
So the Structural Heart Program is a new program here at the Cardiovascular Institute, and it encompasses the care of patients with what we call structural heart disease. And structural heart disease is a very broad term that essentially encompasses diseases that involve either the chambers of the heart or the heart valves. Typically when people think of cardiovascular disease, they think of heart artery disease and heart attacks and that sort of thing. And this is kind of a different realm of cardiovascular disease that traditionally in the past has really been managed more by surgery. And now we're really broadening more into invasive therapies that are less invasive, don't involve open heart surgery, but can really be done through the techniques that we as cardiologists have become very familiar with in terms of doing procedures through tubes and catheters in a less invasive way.
How wonderful is that? Structural heart program or your valve clinic. Now, a valve clinic?
And so a valve clinic is a kind of a burgeoning area of structural heart programs, where it's become in a lot of ways the foundation of most structural heart programs around the nation. And it's really focused, as it sounds, on the heart valves. And it's really become a very team-oriented approach where it's not just cardiologists that are seeing patients and deciding what therapies are geared towards or geared best towards patients, but really involving a true multidisciplinary, what we call a heart team, that involves not only cardiologists that specialize in procedures, in non-invasive imaging, et cetera, but also cardiac surgeons who traditionally have done the open heart procedures, cardiac anesthesiologists, case managers, nurse coordinators. It's a big project, and the goal of this project, goal of these clinics is really to see patients with valve disease, whether it's valve leakage or valve narrowing, and coming up with the optimal therapy for them, whether that's open heart surgery in some lower risk patients or catheter-based therapies where new valves can be implanted through small tubes in their leg as opposed to incisions down their breastbone.
Wow, it's fascinating. What is TAVR?
So TAVR, or TAVR, it's
TAVR.
Yeah, the Europeans actually call it TAVI, so you weren't too far off, or TAVI. But it stands for transcatheter aortic valve replacement, and that is really one of the cornerstones of a structural heart program and of our structural heart disease program here at the Cardiovascular Institute. And that's essentially the procedure that I was talking about before, where for certain patients with a narrowed aortic valve, which is the heart valve that separates the main pumping chamber of the heart to the main pumping artery of the heart, when that valve becomes narrowed, patients have symptoms of shortness of breath, chest discomfort, etc. Traditionally, those folks, the only treatment for that would be open heart surgery and valve replacement. But we all know that there are many patients out there that are either too high risk for open heart surgery or have a contraindication to open heart surgery for a variety of clinical or non-clinical reasons. And so TAVR has really come to the forefront as being an alternative to open heart surgery in the right patient, where a new heart valve can be implanted through a tube in the leg or a small incision maybe up in the shoulder or under the left breast. Typically they're done through the leg artery, small incision less than 1 centimeter in diameter, and patients can go home within 1 or 2 days.
And the recovery from that?
The recovery is almost immediate. I mean, patients typically feel better almost immediately. Our patients here that we've treated have left the hospital on average in 2 days after their procedure, resuming their normal activities.
And you said the patients that would normally get open heart surgery, I mean, is that going to be a thing of the past now?
It may. You know, I mean, the indications for open heart surgery, or the indications for TAVR are still expanding, and currently it's only FDA approved for patients that are at high risk or prohibitive risk for open heart surgery. Now down the line that will extend to patients that are slightly lower risk and maybe surgical candidates, but may have another reason to not have open heart surgery, whether it's recovery, etc., personal reasons, etc. But for now, it's really indicated in a certain subset of patient. Looking down the pipeline, I think it's very realistic to assume that the vast majority of aortic valve replacement procedures will probably be done in a TAVR type fashion or a more minimally invasive fashion than the traditional open heart surgery. Now, that being said, there are still plenty of patients out there that are very good candidates for open heart surgery, and it really still is the gold standard, and has traditionally been the gold standard for treatment of aortic valve disease in the past, and there will always be a place for it. But the indications may change as time goes on in the patient population, as patient populations evolve and indications evolve. The nice thing about the structural heart program and the heart team approach is everyone is still involved, and it's not one group taking procedures and patients away from the other group. We work hand in hand with our surgeons. Our surgeons are down there during these TAVR procedures. We're all involved. We all are caring for the patient, and so the goal is just to do what's right for the patient.
This is probably the latest technology. Is there anything else going on that we need to know about?
Yeah, there's a lot coming down the pipeline, and I think the interesting and very exciting thing about structural heart disease, it is really the next frontier of cardiovascular disease care in the U.S. And you see a lot of new technologies in Europe. Europe always tends to get technologies before we do, but even now expanding to other valves. So not only the aortic valve treatments and the technologies continuing to improve, shorter stays, better technology, better valves, but also expanding to other valves, more specifically what we call the mitral valve, which is the valve just upstream of the aortic valve that separates the top left chamber of the heart to the main pumping chamber of the heart. And there are already devices out there which we have access to here at the Cardiovascular Institute that can be used to treat and repair the mitral valve when it's very leaky. And coming down the pipeline, there will be actual replacement technologies as kind of an adjunct to surgery. And again, in those cases where maybe mitral valve surgery isn't a great option for a patient with bad mitral valve disease, whether it's narrowing or leakage, that we could replace that valve again through a tube and a less invasive approach and hopefully a shorter hospital stay for that patient.
Patients are living longer than they used to, aren't they?
They certainly are, yes.
And you're going to see that they continue to do that.
Yeah, and I think that's the other thing about this is the number of patients out there that are going to qualify for therapy as the baby boomers get older. I mean, what we know is that the older you get, the more patients have valve disease. And if you look at the curves, as the baby boomers get into that 60, 70, 80-year-old range, that's where we see the majority of patients with significant valve disease that need to be treated. There will always be the younger subset of patients with what we call true congenital heart disease that will always need to be, watched and treated at centers of excellence. But the largest population will be that 60 to 90 population, which in the next 20 years is going to be a very large population of patients.
Gosh, I'm glad you're here because guess what? I'm a baby boomer. Dr. Michael Kim, thank you so much. Cardiovascular Institute, we're delighted you're here. How are you liking Colorado, by the way?
I'm loving it. I love living here. Yes.
Yeah, good. We all do. With Banner Health and Spirit of Women, I'm Susan Moore.